Oh, you.
We can't hear you.
One second, ma'am. Over to you, Rija.
Thank you, Sinia. Hello, everyone. A warm welcome to all. In this session, we will be discussing about palliative care delivery and IDT interdisciplinary team. As we have seen in the last session, that palliative care is an approach which includes the overall health aspects of an individual, like a patient and his or her family, and mainly focusing the people who are associated with any kind of life-threatening illness. And it focuses not only the physical aspect, but also the psychosocial, spiritual, and overall health aspect of a particular individual. So as we know, there are a good number of professionals who are included in the interdisciplinary team who are there to cater in different needs of a patient and his or family, like doctors, nurses, counselors, social workers, physiotherapists. A lot more people are included in this. So this is actually an integrated approach which considering the overall aspect of a health, which includes physical, social, spiritual, and financial overall aspect of an individual. Now let's have a look in detail in the interdisciplinary team approach. And I would like to welcome our faculty of the day, Dr. Sanghamitra Bora, who lead in palliative care in Assam Cancer Care Foundation. She has completed her MSc Palliative Medicine, Cardiff University, UK in 2017. She is a volunteer of Arujjeevan Healthcare Foundation, an active IAPC national faculty since 2010, national trainer for National Health System Resource Center, Ministry of Health and Family Welfare, Government of India, a very active member of various palliative association and close friend of Palliative India. I would like to welcome Dr. Sanghamitra Bora. Over to you, ma'am.
Thank you so much. And it's really good to be back with Pallium for taking another lovely session. And I have always experienced the interactiveness of all the participants, all the candidates who take up these courses. So I would be very happy if today also we get to interact with each other, because it is not a teaching process, it is an interaction between different people, exchanging views. Whatever I'm going to show today to you may not be complete in itself. So I always encourage that you should go back and read the literature from your end and try to find out more knowledge into it, and generate your own interest in your subject. So I'll try to share my screen and then we'll get going. Okay, so let me know if you are able to see my screen. So is my screen visible to everyone?
Yes, ma'am.
Okay, so I'll just put it in a presentation mode. Okay, so we are going to talk about palliative care delivery. And, in any kind of system, any kind of process, we need a team approach. It's always better to have a team. So it is same for, delivering the best palliative care to our patients. And for that, we need a interdisciplinary team. So that is what we are now going to talk about. So before going to that, let us just see what a team means. So it's a small number of people with complementary skills who are committed to a common purpose, performance goals, and approach for which they hold themselves mutually accountable. That means there would be people who have certain skill sets with them. They come together with a common goal, okay? They have a common purpose of delivering a certain performance or reaching a certain common goal, and they have a an approach for which they mutually complement each other. For example, if there is one doctor in a team and there is another nurse, so whatever skills the doctor has and the nurse has will not be the same. So the doctor will complement the nurse's work and the nurse will complement the doctor's work. So that's called a team. So what is an interdisciplinary team? What does it mean? So it is an identified collective, right? For example, you need to understand properly what the skill sets of this particular team member has. Okay, so it is an identified collective in which members will share common team goals and work independently in planning, problem solving, decision making, and implementing and evaluating the team related tasks. So it is actually very easy to realize or understand that a doctor in an interdisciplinary team, or a nurse and a social worker or a counselor, they will share one common goal. For palliative care, if we take that as an example, our goal is to deliver the best care, or the relief of suffering for a palliative care patient who is in the last stage of his disease. Okay, so if we take this as an example, then the doctor will work, try to sort out, or try to chalk out a kind of a treatment plan for that particular patient from the physician's point of view, and the nurse will chalk out a nursing plan for that particular person from the nursing point of view, and at the same time the social worker would chalk out a plan where the patient and the family members get the best benefit from those plans, and also try to involve other agencies from where this particular and his or her family can be benefited. So interdisciplinary team is a team who share a common team goal. Okay, so coming to the objectives, what are the common objectives? Firstly, an accurate and speedy assessment, okay, of the problem, or if we can say the patient's work, and then effective integrated treatment and care. Effective integrated treatment and care, then efficient communication with the patient and the family, with other professionals, institutions, and within the team itself, and the audit of the team activities and outcomes. So firstly, the team should do an accurate and speedy assessment of the problems faced by this patient. Then there would be an effective and integrated treatment process and care process laid down for this patient. There has to be good communication with the patient and the family and with other professionals. For example, if the patient is being looked after by an oncologist or a surgeon, or maybe a psychiatrist for that reason, So this particular team should also communicate with these professionals. And if the person is, in the middle of this care process, is being admitted into the hospital, then this team should also have an effective communication with the hospital authorities, the team that looks after this patient in the hospital. And then, of course, within the team members also, within the team members of the interdisciplinary team also. And not last but not the least, the objective should also be to audit the activities of the team. When we say audit, we mean that we are actually trying to critique our own work, okay? Whatever we have planned, whatever the doctor has planned, or the nurse has planned, or the social worker, or the counselor, or whoever is it may be a physiotherapist in the, everybody will critique or audit the activities and, what was the outcome of that particular work, okay? So that is called the audit. So audit is also a very important objective. So how does a team form? So it's a very interesting slide, and I really like to talk about it because, it's like a journey which everybody in a team actually goes through, okay? It's a kind of a metamorphosis from a scattered kind of a thing to coming to a very conducive, lovely environment to deliver the goal of the team. So you can see there are 5 stages of formation of a team. On the x-axis, you can see it's the time, and on the y-axis, it is the team effectiveness. So both of these, the team effectiveness and time, go hand in hand, and they are directly proportional. When I say directly proportional, it means that the effectiveness of the team is dependent on the time of formation of the team up to the performing stage of that team. So what happens when in stage 1, which is forming? So what happens? So people are, they come together to form an interdisciplinary team. For example, suppose, you have been employed in a new organization, and by virtue of the organizational system, you have been told that so from tomorrow onwards, your work is going to be, inside this particular team, where say home care team. Okay, so you are inside this home care team. You are appointed as a doctor or a nurse or a social worker, and you are going to take care of these patients. So these are your duty timings, and you have to report to the head of the team at this particular, assign your patients, and you have to perform. Now, what happens? Everybody is new in this team, okay? And they're so enthusiastic, and they want to give everything to this team, all right? They want to perform to the best of their ability. Everybody has had a background of their own knowledge. They are the masters of their own work. And now they have joined this great organization to, contribute to the betterment of these patients, right? So now everybody comes together. But what happens in the second stage? It is the stage of storming. So what happens is that the team members start experiencing conflict. So why does this happen? That's because, we always start disagreeing to what the other person says. And it is not because everybody is bad. It is because of human nature, okay? It is absolutely because of human nature. So what happens? They start having conflicts. They start disagreeing to what the other person is saying. Say, for example, the doctor says that today we are going to discuss on the treatment options of this particular patient assigned to us. But the social worker is actually not agreeing to that. He says, no, no, no. The physical part is right now not important. I think we should take care of the social part, because the patient is poor and he doesn't have money for treatment. You as a doctor will advise so many medications to the patient, but where will he find the money? He is a poor patient. So, these kind of conflicts start arising one by one, and people are so disappointed. They, at one point of time, they think that I am in the worst possible place. I have never experienced this in my life. I have joined so many organizations, but this is the worst one. I have I have experienced since the last 20 years, and I have mastered in my own subject. How can somebody say something like this to me? So this is the kind of a storming stage. And when you look at the y-axis in the team effectiveness, the storming stage, the effectiveness of the team is zero almost. It is nearing the lowest part of the graph or the curve. Okay, so storming is a natural process. But then, there would be one instance in the teams, in the life of the team, where everything will start slowly cooling down and falling into place. And that instance might be a assignment of a patient, a dying patient. The team may suppose the team has been advised that tomorrow you as a team will go to this patient, and this patient is at the end of his life, and he is a poor patient. Maybe he has a problem in the cheek, and he has an ulcer wherefrom he is bleeding. He is unable to eat. There is a tube in the tube in the nose that goes to the stomach, which we call it as a Wright's tube. And there are family members, but then they're so poor. So there are numerous problems with this particular patient who is going to die, and you as a team have to go and give your support and care. Okay, so that particular instance might be a turning point in the life cycle of the team formation, where everybody now starts taking things seriously and work towards the common goal. And the common goal here is taking care of this person, of this patient who has been assigned and who is in the dying state. So the team goes there, all right, and everybody actually, since everyone in the team has come with a common goal. And what is that common goal? That is to give relief to this dying patient. Okay, I'm taking palliative care example only. So they go and they see that this patient is extremely poor. He may not have had a bath since quite some time. They do not have any resource, for help. He may not have had water properly, because of which he is dehydrated. So the doctor comes in and, and he examines the patient. At the same time, the nurse actually steps forward, and she offers to help the patient with the ulcer that the patient has on the cheek. And then the social worker, without anybody's instruction, he goes and starts talking with the family members, that how they have been, taking care of the patient. What do they need? Where from they buy medications, or do they have any kind of government help. So they are actually performing individually, but inside the team. And that particular work, that particular performance is actually coming very naturally to every team member. Nobody has advised, nobody has told them. It's only the direction that you as a team have to go, look at the patient, and give the best possible care. But nobody has advised that the doctor has to do these things. Nobody has instructed the nurse that you have to go and do these things. So how do they do it? It is out of their own natural instincts that they are working, but they are working inside the purview or regulations of a team. So they now start understanding each other, and they understand how to make it work. And this particular stage is the beginning of the norming stage. So in the norming stage of team formation, you can see the effectiveness of the team is slowly increasing. Okay, slowly it increases over a period of time, and then it reaches the peak of performance where the team starts working extremely effectively and efficiently. And this is the time, or this is the stage where the interdisciplinary team bonding is the best. The doctor understands the requirements of the nurse appreciates every move that the doctor takes, the social worker appreciates everything that has been done by the nurse and the doctors. Okay, and there is no there's no gap between what they think. They think on similar lines. They think on a similar pattern. And the best thing that can happen is that they're always thinking towards betterment of performance. Okay, so this particular stage is called performing, and the team works effectively and efficiently in this particular stage. I'm not going into adjourning or disbanding the team, because I want every team to keep on performing. There will be other additions to a small team. It might start as a 3-member team. It might also happen that there would be 10 members inside one team. Still they would actually go through these stages of forming, storming, norming, and performing. Okay, so this is the stages of team development. And if you ever work in a team or have worked in a team, you may have actually experienced these stages. But those who have not experienced, even if you experience these stages, please try to recollect what I have shared today, because these are the very natural things that might happen. And do not get scared by seeing these kind of changes inside a team. Do not get threatened that your existence may not be taken into consideration. So you are always going to be an important part of a team, because your expertise as a doctor or a nurse or a social worker or a counselor or a physiotherapist will always be there. And if you are not in the team, a major part of expertise is deducted from that team. So be a part of the team. Always go through these kind of stages, and always be confident that at one point of time, the team is going to perform very effectively and efficiently towards taking care of the patient. Okay, so next we come to the characteristics of effective teamwork. So what are the characteristics that determine effective teamwork. So there are three things, three columns, as you can see in this slide. First is the organizational structure, followed by individual contribution to the teamwork, and then the process of team, the team processes. So coming to the organization, any kind of team, whether there is one team or there are multiple teams, they belong to an organization. So for a team to work effectively, there has to be a good organizational structure which has a clear purpose. Okay, and a clear purpose always means that an appropriate culture has to be brought in, a culture where there is constructiveness, there is promotional activities, there are certain aspects which is going to develop the career of a person. Okay, that is appropriate culture. And then a specified task. What is the specified task of of a palliative care organization? That is to give relief to people suffering with serious illnesses like cancer, like paralysis, dementia, etc., etc. Okay, so those are the specified tasks. Every person inside the organization, starting from the head of the organization to the lowest person, lowest cadre of person, must have distinct roles. Okay, and there might be some kind of overlapping in roles, but then everybody will have to have a distinct role. And then a suitable leadership. A suitable leadership will always, take the organization on a progressive path. Relevant members of the organization will also be there to support the whole structure of the organization. And then nothing is complete without adequate resources. Okay, and when we talk about adequate resources, it may be money, it may be the funds, it might be the proper skill set of a person, of maybe a doctor or a nurse. If we do not have them, then the resources, then we are lacking on resources. Okay, so organizational structure, with a clear purpose is a basic requirement for an effective teamwork. Then coming to the individual contribution. Self-knowledge, I will not go into details because you know the importance of knowledge in a person's life. You also understand why it is important for everybody to improve on their knowledge. At the same time, there has to be a lot of trust. If you do not trust your team members, if you do not trust the organization, if you do not trust your leadership, then you will never be able to contribute, okay, towards the greater goal of the organization. You will need to be very much committed to what you have been assigned with, okay, honest in doing that assignment. And at the same time, you must be flexible. There must not be any fragility while you try to work in the team, because if you are fragile, you will not be malleable. Okay, so flexibility is very, very important. Coming to team process, coordination, communication, a lot of cohesion, joint decision making, managing the conflicts inside a team. See, I cannot say that there will, once the team is formed and is in the stage of performing, there will never be any conflicts. There will always be conflicts. And if there are no conflicts, it means that the whole team is stagnated. Okay, there is no development. So criticisms and conflicts will always be there, but it has to be a constructive one. If you do not constructively have conflicts, that means you are stagnated, you are not going forward. Okay, so you'll need to have them. But having said this, there would be conflicts that might go out of hands also. People might, since we are human beings, we might take things personally. So we will need to identify conflicts and manage it then and there. Okay, so conflict management is also an important part. And it is not like one person will only have the skills to manage conflict, so everything will be dependent on that person. It is not like that. You know, it may be a very junior person in the whole team who is a master in managing conflicts. Okay, so the team has to realize these things over the time. There will be also a good fair bit of social relationships, and then performance feedback from people who are actually taking your services. So these are the characteristics of effective teamwork. So what is the palliative care team all about, right? So it is an inherent feature of palliative care. Without teamwork, palliative care can never be delivered. Okay, but there are examples where you find a solo practitioner model where a nurse who is very much interested in palliative care has undergone so many trainings on palliative care, have gone to an extent where she has funded her own studies for palliative care degrees. They may not find somebody to help them, and they would take an individual decision of doing good for palliative care patients. Okay, so those kind of models are also existent. Especially there are people in India who are trying to do their best for palliative care patients, and if they are not stopping themselves because because of an absence of a team, they're doing it alone. They go for home care alone. So those people are also regarded as a solo practitioner model, and you'll find references of solo practitioner models. So once you start with the solo practitioner model, later on you will see that good people are ready to join you, come and work with you. Okay, share the burden of work that you have, and that slowly builds up an organization. Okay, so teamwork has to be an inherent feature in palliative care. Then essentially an interdisciplinary team with its own characteristics and challenges will also be there. The palliative care interdisciplinary team should be both defined and flexible. Defined in the sense that they have to have a set of defined roles for all the team members, and flexible because if say at one point of time the doctor is on leave and there is no doctor, so the team is then led by somebody else. It may be the nurse or the social worker, but the work of the team goes on. Okay, so that is what I mean by the defined and flexibility of a team. So generally there is a core team and there is a extended team. In the core team, we have a physician, we have a nurse, and both of these are generally considered as essential members. This is because our patients are having health-related issues, and that is the reason why a physician and a nurse are essential members. Okay, but having said this, a social worker, a chaplain, or a pastoral worker, a therapist are also included depending on their availability of adequate resource. If they are not present, then the physician and the nurse would be actually trying to play the role of a social worker also. And in an extended team, you may wish to include a psychologist, a physiotherapist, occupational therapist, dietitian, nutritionist, specialist palliative care services from oncology, neurology, and the list can go on and on. Okay, they can be an Ayurvedic person, they can be a yoga therapist, they can be a music therapist, they can be a dance therapist. So it's like an extended team would be quite a long list. So you can go on adding. But having said this, for a palliative care delivery interdisciplinary team has to be the core team of a physician and a nurse. Now, the question, just give me 1 second. So, next question is, do we consider the patient and the family the team members? Do we do that? Yes, absolutely. Why? Because palliative medicine as such is always patient-centered. Well, every field of medicine is definitely patient-centered, but then the advent of palliative medicine, started only to taking. So has to be patient-centered, and all, all treatment must be given with the patient consent and in accordance with his or her wishes. So generally, at present in India and in the other parts of the world also, the patients that we get while in palliative care are almost 70 to 80% in the advanced stage or of their diseases, or are going to die within the next 1 to 2 years. So those patients, their wishes must be actually have to have a importance in everybody's life. So that is why all treatment that we suggest, and that treatment may not be essentially medications, that may be a part of the yoga therapy also, may be a part of the other therapies, including a physiotherapy also. So that has to be okayed by the patient. There has to be the patient must be the part of that particular decision. Okay. And hence the patient must be considered part of the team. So that is the reason why we consider the patient as part of our team. At the same time, the family members will have important role in the overall care of the patient. Say, for example, if you have a team which has been assigned a patient 20 kilometers away from the center, we cannot promise that we will every day go and visit the patient and do everything that is needed. We can go to the patient only, say once a week, or maybe once in 3 days. Okay. And we can spend a maximum of 1.5 hours to 2 hours with the patient. But what happens the rest of the time? Who takes care? So that is the reason why family members have an important role. Okay. So the family members, unless and until they are in our team, we will not be able to provide the best possible care to our patient. Okay. So family members are the extended members of the interdisciplinary team. So henceforth, all family members must be given that importance. And their opinion should be included when formulating the plan of treatment and care. For example, if we don't do that, if we think that, okay, she is a small girl, she's around, say, 13, 14 years old, and she doesn't have a role in taking care of her father, okay, or maybe say grandfather, okay. But the grandfather is happy when the girl is around. The grandfather says that she is there to give me a glass of water. My grandchild is there to bring me this medication. She is also excited that the grandfather is being taken care. I am the one who's giving medication. I read stories to my grandfather. Okay, so these are very small things, but they are very important things. So when we formulate a plan of treatment and hand it over to the family members, it is important that we discuss everything with them, because after you go away from the patient's home, the family members are the ones who are going to execute your plan, and your plan's success will always depend on the family members, how they perform, how they have given, how they have understood what you have instructed, and are they really interested to take care of the patient. So that is the reason why the patient and the family are also part of the interdisciplinary team. Now, coming to members, there are, as I said, there are many others like chaplain, except for the nurse and the doctor who is part of the core team. There are many others: chaplain, occupational therapist, as I said, music therapist, physiotherapist, dietitians, nutritionists, yoga therapist. You can keep on adding whatever, because every person who contributes to the care of a patient, it may be the village headman also. It may be the school teacher who teaches in the village school also. Okay. So everyone will have, I will share with you one experience of my own, because I underestimated one person, but that was the person who actually helped us to take care of a patient. So what happened? There was a patient who died actually. She was an old patient and she was paralyzed for over 20 years. She was bedridden. Okay. And we had a call that we have to go and see this patient and advise. So we went there, and the patient, was staying in a village that was around 20 kilometers away from our center. And, there were neighbors who used to come and see her. And there was, I think there was she had a daughter-in-law and nobody else, because the husband was also, he also died or something. So only the daughter-in-law and the patient lived together. And there were people from other houses of the same village who used to come and help them. They're very poor people. And interestingly, they did not know, how to read and write. Okay. So we had to teach them over video calls and Zoom calls, but they didn't have a mobile phone. So there was a person who used to run a PCO, okay, a public call office that we had so the PCOs are still there in many interiors of our villages in India. So there was a person who used to run, and he was a very young chap. Whenever we called him, he used to run with his mobile phone to their home, and he used to facilitate a video call. So you see how important this person was for us. Once, if the person, for some reason, he was not there, we were not able to even see what the patient was doing, what the patient needed. So must not see the extended members of an interdisciplinary team will keep on increasing. The point is, how do we take people along with us and make them responsible for patient care. Okay, everybody will have something or the other, however small, to contribute to patient care. So you can go on increasing this list one by one. Okay, so there are many different settings for palliative care delivery. There are many places where you can do it. You can sit at your home, you can do a video call, a Zoom call, you can design an app, you can do any damn thing today in today's world to give the best possible care. Okay, and it is not only for doctors, it is also for social workers, it is also for yoga therapists. I have a friend sitting in Bangalore, and she is a triple negative breast cancer patient, a survivor, and she has been teaching yoga online for other, free of cost, for other patients of her age, and inspiring them to fight with breast cancer. So there are a ample number of examples in and around you who will actually inspire you to do this kind of a work. I'm not saying that you should go out of the way and leave your job and just sit and do. No, it's not like that. It has to be complementary. It must be rewarded. Okay, but the kind of reward will be different for different people. This friend of mine, who's a triple negative breast cancer survivor, her reward is to her reward is to teach those patients who are still suffering with breast cancer, and she does it by doing yoga for them and teaching them how to do it. Okay, doing meditation, yoga, and that is online, and she's doing it free of cost, right? So similarly, if you want to do something, start on your own. You can actually do it from the corner of your home also. You just have to find out what you can do. You have to define what you want to do, not like doing everything extra, but something which you can do it, which is going to give the best output. You'll have to find it yourself. So you can do it at home. There would be a lot of outpatient facilities. Now many facilities are there all throughout India. Wherever there's a directory maintained by Pallium India also, where you can find outpatient facilities throughout India. And then you can do a palliative care work in daycare centers. Also, you can dedicate one small space for people who can actually come down and spend. Is an acute care facility. There are specialist palliative care units. There are hospices. Okay, so you can do palliative care, proper palliative care in different settings. All right. So home care teams are those teams who actually provide specialist advice, and they work alongside the community person. And the best example you will see in the neighborhood network community in Kerala. Okay, I have had a beautiful experience when I had my training in Pallium India. That was way back in 2009, and at that point of time, I experienced how strong the community palliative care can be. Okay, once people realize, those people who are common people, once they realize how important palliative care is, they can bring wonders to give care for patients who will need palliative care. So home care teams generally, they provide specialist advice, and they work alongside the community personnel in the community. And community personnel, they may be volunteers, they can be social workers, not necessarily working in palliative care, but they are present in that particular community. They can be also physiotherapists. Local general practitioners are very, very important people, because suppose the doctor is not present, okay, but then there is this practitioner, local GP, who sits every Thursday, maybe Thursday, I'm just giving an example, in that particular locality, and he knows every nook and corner of that particular area. He knows which patient is suffering from what medication are being given. So these general practitioners can be extremely helpful. So home care teams actually are, they get a lot of advantage by working with such local general practitioners. Then the community workers, they generally coordinate the care of patients, forming a bridge between the specialist palliative care team and the home care team. Okay. Now, everything in our lives they have two sides of the coin. One might be an advantage, another might be a disadvantage. So advantages of having a home care team, maybe more than 70% of people would actually prefer to die at home, and that is the reason why they may consider, or they prefer to have a home care team coming to their homes and providing medications or care process, or defining what to do and what not to do for a patient who want to die. Okay, there is more autonomy, there is more privacy and freedom, and patients will feel more safe at home, right? So I would personally want to die at home, because my room will be my room, my home will be my home. I am very safe here. I can actually order my people to bring me whatever I want to eat. Okay, but that is not possible in a hospital setup. So at the same time, one more good advantage is that the family is always around, okay, and they can anticipate the loss. When they anticipate a loss, they know that our father is going to perhaps go away, leave us after another 48 hours. So, they do all kind of rituals for the father. They would do everything that the father would need to do. The father might also want to do a one-to-one conversation with the wife, with the children, tell them what he wanted to do. There may be issues where one would want to say sorry to one another, So all these things would happen in a home setup. The acceptance of death is better. There'd be a good bereavement after the loss. So this is the advantage. And last but not the least, it will definitely reduce the cost of care. Okay, getting admitted would be a lot of disadvantage, a lot of cost in today's healthcare situation, and definitely prevents unnecessary hospitalizations. Coming to the disadvantages of home care, it may be difficult or impossible. I am scared. I do not want to remain at home. I want to go to the hospital. I want to get admitted to the hospital. So for that reason, the patients wish we have to take the patient to the hospital. And it might also be that the patient lives alone or lives very far, where there are no home care teams nearby. Okay, and many times there would be a lot of symptoms. For example, a patient with lung cancer may have a lot of breathing problem, which will need a lot of skilled care in that manner. It will be very difficult for the family members to actually experience that particular problem. It's difficult for them to see the breathing difficulty being increased in while the patient is going to die. So this is the disadvantage. The family is physically or emotionally tired. They cannot deal with uncontrolled symptoms. They are unable to meet with minimal comfort needs also. This is another disadvantage. And then, there is just one caregiver. And suppose it's the woman of the house, okay, who has to look after the kids also, who has to make the food also, and who has to take all the instructions from the home care team also. And that becomes a huge disadvantage. Okay, so this is the advantage and disadvantage of a home care team. So you can see these pictures are real pictures of home care teams catering to people. So in India also, we do home care. We have a lot of good home care teams working for community people. Coming to the outpatient facility will, the advantages is that the patient can have a consultation from a multidisciplinary team. There may be good family meetings, counseling, support group activities that can happen in the same place at the same time. And in case of very severe symptoms of a patient, a daycare symptom control can be easily arranged in that particular facility. But the disadvantage is that patients, if the hospital or the facility is too crowded, patients may have to wait in long queues in OPDs. And then there might be a lot of space issues. Severely symptomatic patients may require a more comfortable space, and you cannot actually promise a lot of space to one particular patient. Okay, then consultants from all disciplines may not be available on the same day. So patient might be required to visit the facility repeatedly, sometimes on a daily basis also. Coming to daycare center, the symptom control can be easily achieved by keeping a patient under close monitoring, where we have good daycare centers, and there would be especially a specialist palliative care team working for them. Patient can actually go home after a short day course of medications or interventions, for example, blood transfusion, fluid replacement, pain control. So patients can spend the whole day and they can go home. But it may not be a very cost-effective option for these patients. And the treating team may admit only those who are not in the end of life, okay? Because they want the patient to be controlled of the symptoms, get the relief, and go home the same day. So whoever is in the end of life, the treating team may actually say that this patient is perhaps not the right candidate for getting treated in the daycare center. And this might actually frustrate the patients or the relatives also. You can do palliative care in intensive care units. I don't know how many of you have had the opportunity to work in an intensive care unit, but we have very, very sick patients in ICUs, in HDUs also. But nowadays, the trend and the WHO mandate is that every patient in an intensive care unit also must get the palliative care consultation done. A palliative care, interventions should be available to every patient. That may be in neurology or respiratory problems, neurosurgical patients, patient in cardiac units also. Okay. Then we have a specialist palliative care unit, which is seen. We have that in Pallium India provides that. All India Institute also has. My organization also has. So specialist palliative care units are distinctively designed, and they are designated for terminally ill patients who require intensive involvement of a specialist team to be able to manage their complex problems. Okay. And all the members of the specialist palliative care team are exclusively trained in specialist palliative care only. Okay. And they function as an inpatient stabilization unit, and they manage uncontrolled symptoms at the end of life. So you definitely must have heard about this term called hospice, and it ensures the best quality of life and the best quality of death also for patients. So a hospice generally admits patients who are perhaps going to die in the next 3 or 6 months. Okay, minimum prognosis of 6 months. And the intensive acute care is not provided to the patient, all right, as we provide it in the specialist care unit. There are many hospices in India. In Delhi also. In Guwahati, here in my place, we have a very good hospice, which is called the Sacred Heart Palliative Care Center. And you must be knowing about Karunashra Hospice in Bangalore. And there are many, many hospices that have now come up in India. They are specifically admitting patients who are in the end of life and who have a prognosis of 6 months only. So this brings us to a very important topic, which you all must be very much interested. So what is social work in palliative care? There are many people who are MSWs and BSWs. They have gone through a lot of training in social work, but social work in palliative care is an interesting subject now, interesting stream of work, and there are doing social work in palliative care. So there are generally 3 forces that shape the social work role. Basically, there are non-medical social goals. Okay, it's not necessarily that have to be in and around medicine, but there are non-medical social goals. The teamwork and multi-professional skills required to meet the non-medical goals will define the role of the worker, social worker. And then expectations of patients, the carers, relatives, friends, and as well as various palliative care professionals, including the social workers, will also shape the social work role in palliative care. So what are the non-medical goals? Number 1, express emotional pain. Okay. So how do you do it? You do it by counseling. Okay. So social work also entails a lot of, lot of entities that are basically counseling skills. All right. So it is the social worker in counseling such patients or the family members would actually facilitate expression of emotional pain of these patients or the family of such patients. And there is also the importance of need for exploration of the spiritual pain. So a social worker also explores into the spiritual pain. And then the need for practical help. Such people, such families or such patients are not able to express emotional pain. They are also not able to define or characterize the kind of spiritual pain that they are going through. And henceforth, they are not able to justify or seek help, practical help in these matters. So the non-medical social goals of a social worker in palliative care helps such people to explore emotional pain, spiritual pain, and help them in seeking practical help for these problems. The perspectives of the social worker. What do the social worker think about being in palliative care? What do they think? So they actually, they have to define that what we cannot do. As a social worker, the most important thing that I would actually want to tell others is what am I deficient in, what I do not do, what I cannot do. So number one, I cannot cure pain because I am not a doctor. So please do not expect me that if I am a part of the interdisciplinary team, I will be also able to cure pain. Okay. So this actually defines the role of the social worker. Similarly, they cannot dress bad wounds. They cannot also offer appropriate religious rituals because suppose the patient is a Christian and this social worker is a Hindu. Okay. So will the Hindu social worker be able to define and, delegate appropriate Christian norms or rituals for this particular patient? No. So that thing cannot be expected or cannot be given to the social worker. So this is the perspective of the social worker. And secondly, to see the patient as part of a family and social network. That is an important role of the social worker because the doctor might forget that the patient is part of the family. The doctor might actually see that this patient is, for me, is a patient who's suffering from pain and I have to treat it. But the social worker is the one who actually sees the patient first as the part of the family and then the community also. Thirdly, he also understands the implications of special situations for the patient. For example, the mental health legislation. If the patient is at the end of life, suffering from some cancer, and also, he's also suffering from some psychiatric illness, which deems him, incapable of giving certain decisions, then the social worker is the one who actually understands the implications of such a situation of this particular patient. And he can also become the spokesperson for this patient. Okay. So what are the main areas of social work? Firstly, definitely the assessment of the patient as a whole, intervention, the bereavement, and many other wider roles. But basically, these are the main areas of social work in palliative care. So, assessment includes emotional, social, practical, and financial assessment. And there are, proper formats. There are criteria, there are validated tools which the social worker follows to do this assessment. And at the same time, he or she also assesses and identifies any need for any further assessment that might be required. And then coordinating between disciplines, the assessment for need for specialist help, assessing, at 4 levels, basically, the individual level, family level, physical resources level, and the social resources level also. So assessment in these areas is a very important subject. Coming to interventions, what are the interventions that he might do? And they must be aimed at patients and families in need of help to cope with their situation. So there has to be an adequate and appropriate information sharing. There has to be a proper communication to reach a solution to the problems that are bothering the patient and the family. And then imbibing the confidence to act on those solutions, facilitate the required resources for this patient, and then facilitate bereavement support also. And bereavement being a very, very important part of palliative care, because we deal with we deal with dying patients, and as a team, we have had our own share of mental stress while dealing with bereavement, because if we are new to palliative care and you have not dealt with bereavement, then it is going to be very hard for you. So the social worker in palliative care knows the consequences of doing a bereavement and how to do a bereavement support. So there has to be a one-to-one bereavement support. Okay. That person will also facilitate bereavement groups when needed. For example, there is just one member of the family left after the patient has died. Okay. And that family, who will support? There'll be the community, or there will be similar people who are, who has formed a group, and that group is being facilitated by this social worker. And that person who is presently undergoing bereavement can actually get support from these bereavement groups. Bereavement counseling is another part. Extended grief counseling. For example, extended grief is very commonly seen in people who have lost their children, small children to cancer or some accident, or anything that have actually created this loss. So extended grief is seen, and extended grief counseling is also a very important part of palliative social work. Coming to wider roles, you can keep on adding to this. supporting doctors and nurses to carry out the social work task. Sometimes, we as doctors, sometimes we feel that, okay, I am just a doctor. I am not supposed to intervene out of my doctor work. It's not like that. The social worker in the team actually makes the doctor realize that we are also into social work. The doctors are also into social work. Okay. It extends from simple advice to a leadership role in IDT. There are many social workers, who have actually gone up the ladder to take a leadership position in a well-defined interdisciplinary team. They should be involved in day-to-day decisions on management of patients also, and then many other similar wider roles. We have already spoken about the importance of community liaison, okay? Routine general contact with people, special actions like creating a care package, facilitating the community resources for patients, education of children who have lost a parent, and they do not have anybody to look into. Job for a family member. For example, a person was in a government job and he's died before retirement, and somebody in the family, maybe his daughter who's just completed her degree, is eligible to get the job of the father. The social worker is the one who plays a very important role in getting that job for that particular daughter. Awareness generation, I will not go into details because you all know social workers, how they play a very important role in awareness generation in the community. Involving the family members in the care process, establishing long-term relationships with a bereaved family. There have been instances where a family has lost a patient and they have continued to build up a long-term relationship with the interdisciplinary team. They have continued to be in contact with the social worker, with the nurse. There are many examples like that. Okay. So this is my concluding slide, but this is not the end. There are many things to be learned. I have just given you the tip of the iceberg thing, and I'm sure that I have actually put a small spark in you so that you go back, you review the literature that is available, and then find out more facts and factuals on what social work can bring or contribute towards palliative care. Okay, so it is a challenging and upcoming subject in the field, and you should all be very enthusiastically adopting it as one of your career options. So thank you very much for a patient hearing, and if you have questions, I am ready to answer. I will try to answer to the best of my ability. Thank you.
Thank you, ma'am, for the wonderful presentation. The floor is open for questions now. You can either unmute from your end or put it in the chat box.
Am I audible? I think so, yes.
Yes,
You're
ma'am.
not
Please
audible.
continue.
Yeah, this is Sheetal. I'm from Dehradun, Uttarakhand. It was a very nice session. Thanks to ma'am and to y'all. Basically, even I lost my father last year, and all those disadvantages and the advantages that she had listed down, we were in that same mode of like, whether to go for this or for that. And then we had this ICU thing that we went through, and It's just a feedback that, like, thanks for putting so much of clarity in the thought. Had this session been there a year back, we would have had so much of better quality of life and death of my father. Thank you so much. That's just a feedback. Thank you. One question, is there any such kind of unit that operates in Dehradun, Uttarakhand anywhere, if you know of, ma'am?
I think there is this one of our colleagues from IPC was there, whose AIMS Rishikesh is also there.
Does it have a palliative care unit, ma'am?
I think so. I'm really not sure, but I'll definitely get back to you. I think the directory is actually with Cinia Pallium.
Probably she can share, because
Yeah,
I don't know how we proceed further, because I have just got, because my field is totally different. I'm looking at it from a perspective of art therapist going into this particular stream.
I'm telling you, I think you are in the right place, definitely thinking to do the right thing. And, I am sitting here in Guwahati, and there is a group called Artscape. I don't know whether you've heard about it or not.
No, no, but thanks for bringing it to the notice.
It is called Artscape, ARTSCAPE, Artscape. So you can Google it. I think it's a group of people who promote art therapy, and you can actually get in contact with them and see how you can collaborate with them and do something in Dehradun. I think you are just the right person to do.
Thank you so much.
Because we have been collaborating with them for our State Cancer Institute in Assam, in Guwahati, and also the B. Barua Cancer Institute, which is the Department of Atomic Energy Hospital. So I think you can do wonders with that, because our patients are giving lovely feedback about the whole thing. So please do.
I guess I should just request the organizers to share these details, because the session is recorded. I haven't taken down any more. I've just been saving all the screenshots. That's it.
Okay.
So, but that's what I'm looking forward to, because, like, what I couldn't do for my father, I can do for at least some other people. Because he went through a terrible time, those 6 days. Like, it was not the money that mattered, but that, like, in that pain. And just to, I don't know if I got that much of time. When he was being taken to the hospital, he actually fell. He had a cut here on this thing. He had a bruise, like, bleeding on this part. So it was maybe like a kind of a physical indication that I don't want to go. And we forced him into that, because that same day he was put into ventilator. He went on there for some 1 week's time. I don't know the kind of pain he went through. So it's been there in my mind. It's kind of a regret for me that should we have got him just back home, or should we not have let him, because he was just dropped by the people who came to take him. And I don't think so the hospital was trained in any such kind of thing. They did not even guide us properly. So it was like something. Anyways, but thank you for the session. And if I can request the organizers to share that data that you just mentioned about artscapes, that would be like really helpful.
I think Simia, I'll just give you the details.
Yeah, somebody has put in, Nancy has put something, so I'll just check the chat.
Yeah.
Is that the same thing?
It's the same. Absolutely, it is the same thing. Yeah.
I'll share the details in the WhatsApp.
Yeah. Thank you so much, Simia. Thank you so much, ma'am. Yes, ma'am.
Yes.
Ma'am, there is a question from Lakshana. What would be the educational qualification, if any, to be a social worker in the space of palliative care?
Well, you see, we have, I think Pallium has also started some, because basically you do a DSW or a MSW in social work, and then you diversify yourself, if I'm not wrong, okay? Diversify yourself into certain community work, or you want to go for HIV AIDS, or you want to go for, so palliative care is definitely upcoming. You can, there are many courses that are being run by, I think, a lot of institutions, premier institutions. Sinia, does Pallium India has a course on social work?
Actually, no, ma'am. I think graduation in BSW or MSW. Or Rija can
Yes,
elaborate.
ma'am. We need required a MSW qualification.
Yeah. So I think, see, this is anyway, we are all transitioning from one phase to the other. Even, MD palliative medicine was not existent 10 years back when I came into palliative care. It was not there at all. So we are all transitioning. So I think, don't think that you need a lot of qualifications. You need to have the zeal. You must have the enthusiasm. You must have the heart to do it, and qualifications will follow. So that is how I also started, and I'm sure that the journey will be the same for everybody out here. So don't worry about that. If you are a MSW or a BSW, I think that's enough. You just need to work and gather your experience. Always document whatever you have faced in your career. I mean, it's not like taking certificates and all. It is like documenting your own experiences. Those things are actually going to make your encyclopedia for yourself. So I think that that would be a great thing to do. Yeah.
Thank you, ma'am. This is Lakshna. I just wanted to follow up my the question that I had.
Yeah.
I'm actually a little older, so I'm sort of done with my education, and I don't know if a BSW or an MSW is on the cards for me. So it was good to hear that the enthusiasm and the zeal for this field is
Yes,
important.
absolutely,
Uh,
absolutely. That is the
but-
only qualification you need, Lakshana. Let me tell
Okay.
you, I can give you 100 examples of doctors who are MD in palliative medicine. They have done n number of degrees from outside of India, and they still don't have that zeal to do it. I can give you 100 examples. So first and the foremost, what I have learned from Rajgopal sir and other mentors in my life is that you must have that zeal. If you cannot have that in your heart and your mind, you can never be a palliative care worker. I think, please do not, age is just a number. So this is not a disadvantage. This is in fact an advantage, because as I said, you must have actually resonated many things when you have contacted with people who need palliative care for that reason. And when you have had those experiences, take them as your learning points.
Right.
Just deduce the learning that from this patient or from this particular experience, this is my learning. And I think those are going to help you in the long run, because you are doing something practically which cannot be done by anybody else. That is my personal experience.
Thank you. That's good to hear.
Yes, absolutely.
Ma'am, there is a message which says that there's a 3-day course. What course is that? If you can throw some light on that. Rachel has put in a message, I guess. I don't know.
Pallium India offers 3-day training with certification. Okay.
Is it different from what we are doing right now? This is a basic training, what we are having.
No, there is I think a Pallium India team would be able to tell you. There's a 3-day course for being a volunteer with Pallium India. And there you cover a lot of subjects, so which make you fit to be a Pallium India, to be a volunteer. See, actually, as someone was telling, I am 61 now. So there is no age limit to it.
Absolutely, absolutely.
So is there a stay facility that's there in Pallium India? Because I do have some of the team members whom I know from a different angle altogether. I had taken up a course in API, that's Arts Practices for Inclusion. So I don't know, this course that you have mentioned, the 3 days course, can we come, stay, take the course and go back? I don't know if that's a possibility. Rachel, if you can throw some light.
Can you please give me one minute?
Or you
So,
can also give
ma'am, we do have a state facilitation department here. So I will be sharing the contact details of our regional coordinators with you in our WhatsApp group so that you can contact them. And for the training, currently we are not running any on-site training courses for these volunteers right now in Palliative India. We do have a volunteer training program that's offline. That's like an online course, 5 days online course. We haven't announced the next dates. When it is ready, we'll be sharing the details with you so that you can attend the volunteer training program also.
So it will be an online or offline?
It's an online course. Online course. Currently, we don't have any offline courses or on-site courses here. We don't run an on-site.
So what?
Actually,
Okay,
we
what
don't
just
run any on-site course for this social workers currently.
Not for the social workers. I am a totally different person.
As
I'm an artist.
Volunteer
Yes,
races.
also.
That's what she's telling.
Volunteers also.
Yes. Maybe you can put it in the group.
Yes,
But,
yes. I'll be sharing the details in the WhatsApp.
But having listened to this discussion, I would actually vouch that you should take a 7-day vacation to Palliative India, spend time as a volunteer, just as an observer. And, I can actually give it in writing that you're going to have the best experience of your life. Kovalam Beach is very near.
I've got a lot of invites from
There.
Kerala, so this would be the best. That's why I was asking for an offline thing.
No, you can actually, as far as I know, you can actually be an observer there and, be a part of the home care team. That's what had happened when I was there. I don't know whether this has changed, but I do feel and I do think that it still would encourage people to be, observers for the whole process, the kind of clinical processes that they have. So you can always, I think, write to them and then get that particular. I think somebody, yes, Mr. Rajesh wanted to ask a question.
Thank you.
Please, yeah, please, Mr. Rajesh, yeah.
Am I audible?
Yes, you're audible, please.
Ma'am, I understand there may not be a hard and fast answer to this, but with regard to your formation of the IDT team,
Excuse me, sir.
presentation.
You're not audible.
You are not clear.
Not clear, actually.
Am I audible now, ma'am?
Can you please raise the volume a bit?
The volume is at its peak, isn't it, actually?
Actually, your sound is not clear. We couldn't figure out what you're trying to tell. Yes, you can type it in the chat box, please. About the observation visit, you can come to Palliative India at any time. Just put a mail to us so that we will be making the necessary arrangements. Sheetal ma'am, this is
Did you say something for me? I heard my name.
yes, ma'am. About the observation visit, we still have this.
Okay.
So if anyone wants to visit Palliative India, you can do an observership here. You can just call or mail one of our coordinators. I will be sharing the contact details and you are always welcome here.
Thank you so much. Thank you so much.
Ma'am, can I read the question?
Yeah, can we stay there during?
Note that, ma'am. With regard to the
IDT formation, wouldn't gender of the team member and patient be a factor? for non-medical support. Okay, with regard to the IDT formation, wouldn't gender of the team member and the patient would be affected in non-medical support? I don't think so, Rajesh, because we have had male nurses also. There are certain instances where male social workers have outperformed female social workers also. But I'm not actually, trying. Yeah. So, sorry. So you are not able to hear me?
Yes, ma'am.
So
He actually have put another
I'm really
message.
bad in sign language.
For example, he have put another thing like, for example, female patients may require specialized attention and onboarding family members would be critical. That's what he's mentioning, I think.
Okay. Yeah, no, these are special situations. I do understand that. This is a very pertinent and important question. But it's very important that we make a balance in the whole situation, right? See, in the very beginning, I actually told you that you must not actually be kind of, I have to do it. You have to set your limits. Please do that first. In the role of the social work, you must set your limit that I cannot actually become a nurse and dress bad guns. Okay, I cannot manage pain because I'm not a doctor. So you have to set your boundaries first, right? And if you are not able to justify your work to yourself, then you will not be able to do that for your patients or for your team also. So I think in this particular scenario where female patients would require specialized attention, if you are not able to contribute, then please step back. Let others take the role. And if at the same time, like if you see that the whole team is a little bit shaky about that situation, do not enter into that area at all. Okay, it's always better to withdraw from that particular situation. It is not going to make you a villain, or it's not going to give you disadvantages. No, but if you start doing it and you cannot fulfill that particular thing, then that will be a very bad situation to deal with. So it's always better to step back. Am I able to answer your question? I don't know, Rajesh. Yeah, okay, yeah, please do. All right. Okay, there's a question which says, what is the chief benefit of home-based palliative care service? Okay, I think I've already shown you the advantages and disadvantages. See, every service will have their own advantage and disadvantage. And for home-based palliative care service, the chief benefit, as I would look at, is that we are giving the best possible care, tailor-made for our patients at their own setups, at their own homes, which they may not have really imagined in their lives. Every person would actually be in the fear that one day when I'm dying, I will have to spend the last days in the hospital. So nowadays, this is what is actually, it goes on in everybody's mind, including me, because I'm already 50. And, if I am like going to be 90, which I will never cross, and then I think, oh my God, how am I going to die? If this feeling is a fear in everybody's mind, that how are we going to die, then if somebody comes and tells me, no, you can stay at home and we will come and look after you, I think nothing is, I will not go for any other care, whatever it is. Yes, I am going to be at my own place, in my own bed, So I think that is an important thing. So I think that is the chief benefit of home-based palliative care. Otherwise, there are a lot of advantages, other disadvantages also. But then, the platter is in front. You need to choose it from there. Yeah.
Thank you so much, ma'am. I think we are running short of time. Mr. Rajesh, if you are having further queries, I think I can facilitate your conversation with Dr. Sanghamitra. Okay, thank you.
Okay. Yeah. Thank you so much. Thanks a lot. It has been really nice interacting with you all. Yeah.
Thank
Bye.
you.
All the best to everyone. Yeah.
And
Okay.
I have shared the feedback link. Thank you all.
Okay. Bye-bye.